Assalamu alaikum, everyone. Can I ask everyone to start settling in? So we'll start the session in the next couple of minutes. Okay.
Thank you very much for coming to Peshawar, Dr. Mansoor Bangash. So my name is Dr. Faraz Mansoor. I'm one of the anesthesia consultant here at Shaukat Khanum, Peshawar. So I would like to introduce the chairs first. We have two anesthesia consultants. One is from Shaukat Khanum, Lahore, and the second is from Hayatabad Medical Complex, Dr. Salma. Dr. Hassan is my class fellow. We are from Rawalpindi Medical College. He's presently the anesthesia consultant at Shaukat Khanum, Lahore. And he has played a tremendous role in establishing the anesthesia services at our Lahore center. So I would request Dr. Hassan to please take his seat. Dr. Salma is one of the senior most anesthesia consultant from Hayatabad Medical Complex. She has also worked with us at Shaukat Khanum, Peshawar. So Dr. Salma, please come and join with Dr. Hassan. Thank you very much.
Assalamu alaikum. Welcome everyone to anesthesia and pain medicine session. This is the first session. Another session will be held after this one. We have 3 talks followed by a panel discussion. The first talk, I would like to invite Dr. Faisal Shamim. Dr. Faisal Shamim is associate professor and consultant at Aga Khan University Hospital. He's got special interest in airway. He's also a member of Difficult Airway Society. So Dr. Faisal Shamim, he's going to talk about anticipated difficult airway in head and neck surgery, new tools in evaluation and management. Dr. Faisal Shamim.
Assalamu alaikum. Thank you so much, Dr. Hassan and Dr. Saad and all the organizing committee. It's been a very great honor to speak at this prestigious forum of Shaukat Khanum Cancer Symposium. 2 years back, I have also delivered a talk as an virtual talk, but this is the first time physically present here. And so as my field of interest is airway management, so I choose this topic, especially in head neck cancer surgery. I do ENT head neck cancer surgery list for about 10, 12 years now. You all know my institution. I have no conflict of interest to this program and presentation. And pictures that I have used in my presentation is I've taken the concept. We all know that patients who are undergoing head neck cancer surgery, they are the most difficult ones who are presenting with anticipated difficult airway. And they are the #1 surgical population, percentage of surgical population who have airway management challenges. The incidence of difficult airway intubation in head neck cancer surgeries is much higher than the general surgical population, and predicting difficult airway in general and obstetric population is well studied. We all know about the literature from the literature of airway that there is a famous audit which held in 2011 in UK that is called NAP4, and NAP4 is the largest audit to date have been conducted in UK for about 300 hospitals for a year, and they have looked at the airway management complications in routine and every type of patients. And head neck patients comprised of that audit is nearly 40% of cases who have those airway management complications, and they are the most high risk population who have associated with death and brain damage. So in order to minimize these complications, a complete airway evaluation is required, which include assessment of not only the predicted ease or difficulty of tracheal intubation, but also to predict the success of fallback options like oxygenation, face mask ventilation, supraglottic airway insertion, and surgical airway. So there are published predictors in the literature in Canadian Airway Focus Group who published these recently in 2021. And when we are evaluating our patient, we should always not only look at or not only assess that we can pass the tube only. We also should look at that, are these patients are difficult to face mask ventilate? Are there any predictors which pose some difficulty when we do direct laryngoscopy and when we do video laryngoscopy? So there are few predictors which are especially looked at for difficulty in video laryngoscopy. And then we should also see that what our backup plan. So our backup plan is face mask ventilation, or our backup plan is supraglottic airway insertion. But if a patient does not have any mouth opening, so that means you cannot insert supraglottic airway if you fail in attempting in any kind of intubation. And then also patients who have neck masses, thyroid goiters, they are very difficult to have a surgical access. So we always looked at all the predictors. So to recognize a difficult airway, we need a focus history, examination, and imaging. And the primary priority of these airway assessment is to determine that whether airway is compromised or not. We all know these are examinations. Every day we looked at our patients. We assess our patient by doing these bedside examinations, buck teeth, incisor distance, malum putty, all our 11 component tests. And this systematic and comprehensive preoperative airway assessment is paramount. And ASA 11-point bedside airway assessment tool is a good start. But the literature has also actually shown that traditional bedside examinations and tests lack the sensitivity to predict difficult face mask ventilation, laryngoscopy, and intubation. And also there is evidence also suggests that there are deficiencies in the ability of anesthetists to predict airway difficulties and pathology and plan subsequent airway management. So the traditional test actually failed to assess the severity of upper airway disease, and they also the base of the tongue pathology. So in order to evaluate these head and neck cancer surgery patients, we need some enhanced evaluation. And this enhanced airway evaluation in head and neck cancer surgery is about preoperative imaging and endoscopies. So there are 4 components which are part or which are included in enhanced airway evaluation, and I go one by one. So flexible nasoendoscopy. We all know our colleagues, head and neck surgeons, ENT people, they routinely perform head and neck these flexible nasoendoscopy, which is also called flexible operative direct laryngoscopy, FODL. There are different names to it. And we also inference and we also looked at their notes to see what is the anatomy, where is the pathology, what is the airway looks like on the FODL. But this FODL or this flexible nasoendoscopy can also be used by anesthesiologists. Now, the issue is always, as we are working in Pakistan and the other low middle income countries, the availability of these scopes are not very common to the anesthetists, so they can use in the preoperative area. But a small narrow fiber optic scope can be used, and you can quickly see your patient's airway in the preoperative area by doing a very good gentle topical anesthesia of the airway. So preoperative endoscopic airway examination, this PEAE is the concept given by the Professor William Rosenblatt in 2011. He's a famous professor of anesthesiology in the US, a very well-known name in anesthesia. And he proposes that we can do the preoperative endoscopic airway examination. And in this study, he actually proves that there are unnecessary awake intubations the number of unnecessary awake intubations are reduced by looking at the airway in the preoperative area. So this can provide the precise information about the upper airway and laryngeal anatomy and the upper airway dynamics. Murthy et al. Grades the airway on this PAE for the documentation, communication, and guiding decisions on airway strategy, and 0 is the normal larynx and 4 is the large tumor causing obstruction. Despite giving recommendations in the NAP for the flexible nasoendoscopy is underused in anesthesia, and it has been recommended that it can be considered to use before induction of general anesthesia in patient with neck masses and stridor. However, all procedures, all invasive procedures have some drawbacks and limitations. In emergency setting, with a patient who is in a stridor, you can actually choke and you actually more do the obstruction to the airway, and the patient can go into the laryngospasm as well. Especially the technical skills are required because you need a trained clinician. You may require a specialist equipment, an appropriate clinical setting, and a compliant patient to tolerate this scope in a emergency setting. Ultrasound, we all know that point of care ultrasound is now being used for every part of the body, and every specialty is using the ultrasound. So airway ultrasound is also a simple, valuable, portable tool that facilitates non-invasive, functional, dynamic, and real-side bedside airway examination. It can be used at various stages of airway management, from airway assessment to confirming the position of the tracheal tube and readiness for extubation. The literature has and studies compared the ultrasound with CT scanning have shown that upper airway structures can be reliably visualized and assessed with ultrasound. Now, there are many literature and many articles on ultrasound of the airway, and there are 4 general means by which airway ultrasound can aid in predicting the difficult airway management. The first is by detection of the hidden airway abnormalities like tumors, abscesses, hematomas, and other space-occupying pathologies that can be readily apparent with a relatively brief ultrasound examination. The second is the estimation of the ability of the patient to adequately extend the neck in the upper cervical region. That is a maneuver which we always ask our patients to extend the neck, and that also gives us a clue that the laryngoscopy and intubation will be a success. So this index, which is called hyomental distance ratio, the index is established by placing ultrasound transducer in the submental space in the sagittal orientation and identifying the hyoid bone and mentum. The distance between the 2 bony structures is measured in both neutral position and as well as the hyperextended position, and the ratio of the 2 calculated. In patients with good atlanto-occipital and atlanto-axial extension, the mentum will move away from the hyoid in the hyperextension, and the hyomental distance ratio will be greater than 1.1. So typically, if it is less than 0.9, this may give a clue or give you just anticipation that the neck extension is a little bit restricted and laryngoscopy may be difficult. In order, just a point to note that hyomental distance ratio is more predictive. Alone, hyomental distance is not predictive, which is shown by the evidence and literature. The third application, which is there are different distances are measured from the skin to the invasive airway, the airway structures, and there are many distances are calculated from the skin to one of the several internal airway structures. The most studied and validated appear to be the distance from the skin to the epiglottis and distance from the skin to the hyoid bone. And there is frequently no complete consensus on these cutoff values. So this just may give good clinical indication to do ultrasound of the airway. The fourth is the tongue thickness, and the tongue thickness is the fourth and final measurement that gives a predictive value for difficulty in both laryngoscopy and mask ventilation. A tongue thickness greater than 6.1 centimeter and a tongue thickness to thyromental distance ratio greater than 0.87 have been shown to be independent predictors of difficult tracheal intubation. So also we can look at the other airway structures like thyroid cartilage, the trachea, the vocal cord assessment can be done. You can do a ultrasound airway in the preoperative area before thyroidectomy, and you have a bilateral assessment of the bilateral vocal cord movements, which can be assessed, and you can easily do in spontaneously breathing patient. The other thing which is most looked at in the literature and most common indication of doing an ultrasound is the identification of the cricothyroid membrane for front of neck airway in patients with neck masses, in patients with stridor, in patients whom anticipation is that the intubation is going to be difficult. So a marking of cricothyroid membrane is now becoming a routine before attempting a difficult intubation. So both transverse and sagittal scans have significantly higher success rate in identifying the cricothyroid membrane than traditional palpation and landmark techniques. And this has also been shown in patients with a high BMI and pregnancy. Tracheostomy procedures, identification of the trachea can be challenging, who are obese, have neck masses, have had previous surgery or radiotherapy to the head and neck. So limitation of this ultrasound is that only anterior structures can directly visualize, and ultrasound waves cannot travel through air. This ultrasound identify can the tracheal position depth. CT scans we always do when head and neck cancer surgery list. We always look at the CT scans. CT scans are most of the part of the routine management, and CT and MRI scans are often requested prior to surgery. So I'll go quickly from the CT scans. We all know they have a very good diagnostic tool with excellent risk-benefit ratio. The multi-detector CT rapidly acquires high-resolution data and produces thin slice selections. In tracheomalacia, dynamic airway CT helps assess the extent of tracheal lumen collapse when a crescentic frown shape forms during the expiration. CT is also invaluable in viewing inaccessible areas like pre-epiglottic and paraglottic space. But there are drawbacks and limitations. There is exposure to ionizing radiation. There is AKI can develop secondary to injection of contrast medium. Axial CT images used alone may not adequately display complex 3D relationship. Virtual endoscopy is an excellent tool used to obtain an anatomically similar representation of the intraluminal geography of the airway. Virtual endoscopy is the process by which CT and MRI images can be used to create 3D reconstruction, and this technology has been used to assist in pathological diagnosis and guide biopsies by radiologists and bronchoscopists. Digital imaging, these are called DICOM files, and all of the tertiary care hospitals, these have DICOM files. There are softwares available which can be bought on internet, and you can see these DICOM files on these softwares. This used to construct a three-dimensional fly-through video of the relevant airway anatomy. It results in creating an anatomically accurate depiction of the patient's upper airway that can help anesthesiologists in planning airway management strategies. Importantly, unlike pre-operative endoscopic airway examination, virtual endoscopy can also be used to image deep into the tracheobronchial tree to examine subglottic, tracheal, and bronchial lesions that may be of concern. In patients with head and neck pathology, preoperative virtual endoscopy video enables better understanding of the airway anatomy, planning of the optimal pathway for flexible fiber optic endoscopic intubation in either awake or anesthetized patient. Again, current evidence for virtual endoscopy, Karim Al-Boghdadle, who's in Guys and Thomas and colleagues, demonstrated that adding virtual endoscopy videos to review of conventional CT images, it actually improved the anesthetist diagnostic accuracy of airway pathology by 13%. It led to changes in airway management in half of the cases, and 90% of which involve have a more cautious plan. 3D printing is also being used nowadays, and it is also used in educational purpose. 3D printing is a novel technology that utilizes data from the CT scans to print 3D models. These models are then utilized to simulate a patient's airway. The clear anatomy provided aids airway planning of complicated cases with distorted airways due to trauma, congenital malformations, or trauma. So there are some emerging robotic innovations and artificial intelligence, as we also are hearing about artificial intelligence coming in medical field. Attempts to use robots for anesthesia and airway management have long been reported years ago. The field of artificial intelligence and machine learning are expanding rapidly and have started to play strong roles in difficult airway management. The robotic endotracheal intubation is a novel technique that combines the use of automated systems with the expertise of healthcare professionals. There are 5 of these reported, but 2 merit some discussion: the Kepler intubation system and the robotic endoscopic, which is called Reality. The Kepler intubation system was named after Johannes Kepler, who is the renowned German mathematician and astronomer. He was recognized for his groundbreaking laws of planetary motion. This system comprised of a remote control center, which is joystick, and intubation cockpit linked to a standard video laryngoscope via robotic arm. The other person is a Biro. He also this reality software is now, if you go to the Europe and US conferences, the big conferences, you may come across this reality software. And he also conducted a proof of concept study using a mannequin to explore the potential of this robotic system, which is consisted of a video endoscope that enables manual control of the endoscope via the joystick. So the other thing is the advancements in the artificial intelligence for airway management, which is AI or machine learning algorithm. It is also used to employ to predict difficult airway and difficult laryngoscopy. The AI, actually, they combined facial images in difficult airway assessment. Hayeska et al. Developed an AI model for tracheal intubation by inexperienced medical staff and made a full automatic system to collect patients' facial photos with mouth open, tongue stretched out, head stretched vertically and laterally rotated. And this figure shows then machine learning algorithms were used to analyze and process the facial photos. These combined with the actual results of tracheal intubation and the key facial features are extracted. In their study, the model accurately identified expected difficulty in intubation with 80% accuracy, 81% sensitivity, 83% specificity, and 0.864 area under the curve. Just quickly, there are lots and lots of new equipment coming in the market, so I cannot touch upon all the video laryngoscope and fiber optic, but just a quick, which is our normal, routinely we come across this situation that you do a video laryngoscopy and you have this view despite putting a lot of pressure on the neck by asking somebody to put pressure on the glottis, do external laryngeal manipulation, and you could not see the vocal cords and the glottis. There is a very high anterior larynx. You tried bending the endotracheal tubes by the stillet, and you do a lot of bending, but it doesn't go, and you cannot direct the tube into the glottis despite doing. There are some fancy gadgets like articulated stylets are being used. These devices are characterized by their ability that you can control their distal ends by proximally. So these are the movable bougies now. These are articulated stylets which we can use, and you can by the help of these stylets you can direct the tube into the glottis. The other important technique which I also personally favor and also use in terms of very high anterior larynx, and if the tube is not going into the trachea despite having a view and despite having a the percentage of glottic opening is 25% and the tube is not going in. So you can combine the video, and I'm sure many of the tertiary care hospitals have the video laryngoscope and fiber optic bronchoscope. So combining the video laryngoscope and fiber optic bronchoscope, this is an interesting approach, and this provides several advantages. Both this is also called hybrid intubation. This provides several advantages. Both types of devices may compensate each other limitations in patients, and the video laryngoscope can provide an unobstructed view, and you can pass the fiber optic bronchoscope. So you have two screens. The fiber optic bronchoscope can be manipulated. You can go into the high anterior larynx by moving the tip, and this can be easily if in case of unanticipated difficult intubation where you cannot pass the tube and you cannot have a direct view. We also published 2 case reports in Anaesthesia reports, and just 2 days back in Journal of Pakistan Medical Association, there is a child who have a who is a Hunter syndrome, a very large tongue. He was scheduled in daycare and he was unable to intubate because this is the maximum view on video laryngoscope by one of my colleague. The case was abandoned, patient was awakened, cancelled, and rescheduled, and then next week we do it through this, and I have across same situation, very high anterior larynx, despite now again in video laryngoscopy in very high anterior larynx where the glottis cannot be seen, the bougie is most of the time is very lousy and very friable, and bougie with video laryngoscope is usually fails because you cannot direct video bougie in this direction. In anteriorly, the bougie will curl down and it passes into the and drops into the hypopharynx. So you require something which can take this tube because the angle between the tube tip and the glottis is compromised. So you can try. There is also literature is coming up with the video laryngoscope. This is just for updating that there are now video laryngeal masks are also now available. So in conclusion, the knowledge that much of a patient's airway is beyond the reach of the anesthetist routine examination. This has prompted efforts to improve access to imaging the middle column. Preoperative endoscopic airway examination and virtual endoscopy are two promising tools for airway enthusiasts. The difficult airway is something you anticipate. The failed airway is something you always experience. Thank you so much. एनेस्थेटिस्ट का एयरवे जो है ना वो बहुत ही टची सब्जेक्ट होता है और हमेशा मैं अपनी जब भी एयरवे की कि ये सब कुछ देखने के बाद बहुत सारे गैजेट्स के बाद भी हम कहते यही हैं यार ट्यूब तो मैंने डाल ही लेनी है तो
Thanks very much, Dr. Faisal. A very comprehensive review of what we know about difficult airway as we speak. Do we have any questions? We got a couple of minutes. Any questions from the audience? Okay, we have one. Is anybody going to provide a mic? If you can come here to ask your question, please. Faisal, while he's coming, if I can ask, are we going to change how we examine our patients for airway assessment? Is there going to be a change?
Probably ultrasound will be the answer in by predicting, especially the head neck cancer and the patients with head neck cancer. I think ultrasound, we should start doing an ultrasound airway by looking at least the cricothyroid membrane. So we know that, and we can start marking the cricothyroid membrane, especially in those patients where you are anticipating. I know that anticipated difficult airway are myself and my colleagues will do an awake intubation, but the awake intubation is not always the answer.
Sure.
Anesthetists have this inherent instinct that despite looking at the difficulty, he or she will say let's try, हो ही जाएगा, देख लेते हैं, कोशिश कर लेते हैं, हो जाएगा. और वो जो एक कोशिश में शायद वो 1 to 2% ऑफ केसेस होंगे जहां आप फंसेंगे, वहां आप अगर क्रिकोथायरॉइड मेम्ब्रेन, इसको डबल सेटअप भी कहते हैं. एक लिटरेचर कैनेडियन एयरवे फोकस ग्रुप ने इसको एक डबल सेटअप इंटरवेंशन या डबल सेटअप के एक इंसिशन मेकिंग पर्सन, चाहे वो एनेस्थेटिस्ट हो, चाहे वो ईएनटी सर्जन हो, वो मौजूद होता है, मार्क हुआ होता है. पेशेंट ने अगर रिफ्यूज कर दिया है अवेक के लिए, आपने इंटुबेशन अटेम्प्ट की, फेल हुई, somebody can open the trachea. So this is also called double
take
setup.
a question now, please.
Ji.
Assalamu alaikum.
Walsa.
My name is Dr. Shahzad Khan, resident anesthesia
Ji.
at Shaukat Khanum, Peshawar. My question is that in what clinical scenarios should we awake intubation should be considered preferred approach for managing difficult airway?
So awake intubation, har jagah we should do an awake intubation where you are anticipating कि आपने, there are few questions. एक बाकायदा ASA ने भी दिया है कि पहला सवाल ये है कि एंटिसिपेटेड डिफिकल्ट है, आपके पास रिसोर्सेज हैं, पेशेंट डिफिकल्ट है, एंटिसिपेटेड है और आप अवेक करना चाहते हैं, और उसके साथ अगर आप जनरल एनेस्थीसिया देंगे तो दो क्वेश्चन आपने अपने आप से पूछने हैं. अगर मैंने बेहोशी दी तो क्या, और इंटुबेशन फेल हुई तो क्या मैं इसको फेस मास्क वेंटिलेट कर पाऊंगा, क्या मैं इसको सुप्राग्लॉटिक एयरवे डाल पाऊंगा, और क्या अगर ये दोनों नहीं हुए तो क्या मैं फ्रंट ऑफ नेक एयरवे कर पाऊंगा. अगर ये 3 सवालों के जवाब आपके पास हैं और आप कर सकते हैं, तो जहां ये 3 सवालों के जवाब नहीं है वहां पे प्रेफर्ड यही होगा कि आप अवेक इंटुबेशन पे जाएं. अगेन डिस्पाइट रिसोर्सेज, हैविंग सेड दैट, बहुत दफा वो ट्रेन पर्सन नहीं होता जिसको फाइबर ऑप्टिक आती हो, जरूरी नहीं है कि वो उस वक्त अवेलेबल हो. सो क्वेश्चन अपने आप से पूछना है कि मैं अगर एनालिसिस, तो क्या मैं मॉर्बिडिटी ऐड करूंगा. अगर आप ये कहते हैं कि ऐड करूंगा तो ऑलवेज डू एन अवेक इंटुबेशन. अच्छा, अवेक इंटुबेशन के बारे में एक और, सॉरी मैं थोड़ा सा टाइम ले रहा हूँ, अवेक इंटुबेशन के बारे में एक और जो मिसकंसेप्शन है वो ये है कि सिर्फ अवेक फाइबर ऑप्टिक ही हो सकती है. नहीं, यू कैन डू, अब लिटरेचर में अवेक वीडियो लैरिंगोस्कोपी हो सकती है. फाइबर ऑप्टिक इसलिए प्रेफरेबल होती है बिकॉज स्कोप की टॉलरेंस आसान होती है. किसी के मुंह में बड़ा सा ब्लेड डालना आसान, लेकिन वीडियो लैरिंगोस्कोप है तो आप अवेक वीडियो लैरिंगोस्कोपी कर सकते हैं उसी तमाम टॉपिकलाइजेशन के जरिए जो आपने फाइबर ऑप्टिक के लिए की होती है. आप अवेक डायरेक्ट लैरिंगोस्कोपी भी कर सकते हैं, ठीक है. और अगर इन तमाम सिनेरियो में अवेक इंटूबेशन का नहीं होता तो you have colleagues available and you can do an awake tracheostomy.
Thank you. Sir.
Thank you very much, Dr. Faisal.
Sorry, we've got a very large online audience as well. So I've got an online question for you. So the 3D reconstruction of CT images, it seems a very promising modality for patients, especially in countries like Pakistan, where we don't have the fancy gadgets, but we can do a CT scan. So what is the evidence base regarding management of difficult airways in successful intubation in 3D reconstructed images of CT scans?
3D reconstructed evidence base तो मुझे नहीं पता, उसका तो मैंने नहीं देखा एविडेंस, लेकिन जो virtual endoscopy है उसका तो एविडेंस है. अब जो 3D printing is itself a costly thing, और 3D जो 3D images reconstruction है, I think वो उसी की बात कर रहे हैं जो virtual endoscopy है. virtual endoscopy का तो एविडेंस मैंने बताया था कि वो काफी उसकी वजह से जो है वो एडवांटेज होता है. लोग यूज नहीं करते वर्चुअल एंडोस्कोपी के ऊपर, और ये जो सिमुलेटिंग दी एयरवे वाले जो ये हैं इसके ऊपर डॉक्टर नबील होते हैं इन कतर, उन्होंने बुक भी लिखी है और उसमें बहुत अच्छी इसके बारे में था. इमरान अहमद जो करंट डैश प्रेसिडेंट है, ही हैज आल्सो एन आर्टिकल on the virtual endoscopy in Indian Journal of Anaesthesia, so they can look at this article, which is a very good article on this virtual endoscopy. और अभी तक कुछ सॉफ्टवेयर थे जिसका Ozerix के नाम से आता है, जो कि अभी तक उसका जो वर्जन था वो फ्री था, बट अब नाउ वो उन्होंने भी उसके चार्जेस लगा दिए हैं. बस यस, यू कैन डू दीज, इट रिक्वायर्स सम ट्रेनिंग, जैसे कि हम लेरिंगोस्कोपी के लिए, ट्यूब के लिए, हर चीज के लिए कुछ नंबर ऑफ केसेस वो करने होते हैं, सो आप कर सकते हैं इसको. But evidence is promising in this virtual endoscopy.
Thanks very much, Faisal.
Thank you.
One question, sorry, Dr. Faisal.
Sorry.
एक क्वेश्चन है about the mediastinal masses, बाज दफा tracheal compression हुई थी, तो what do you think about those cases? Which patients are
Mediastinal
at high
masses
risk?
are always very tricky. We all know about this. It does not give a very clue कि जी वो बेहोशी देने के बाद किस तरह बिहेव करेंगे. अगेन वी शुड नो अबाउट, अगर सीटी हुआ है और हमें उसकी कंप्रेशन और वो सारी चीजें पता हैं, सो आई मीन द बेस्ट वे, अगर रिसोर्सेज हैं, ट्रेंड हैं, तो और पेशेंट परमिट कर रहा है, तो आई थिंक अवेक इंटूबेशन वुड बी मोर बेनिफिशियल इन पेशेंट्स विद mediastinal masses, बिकॉज और खास तौर पे यू मे हैव अ कार्डियोथोरैसिक ऑन बोर्ड, ताकि अगर किसी केस में अगर किसी तरीके से आप अगर टर्चरी केयर में बात करेंगे तो फिर तो जाहिर बात है इस तमाम रिसोर्सेज को लेते हुए आप mediastinal masses को, आई एम श्योर बहुत सारे लोगों का mediastinal masses में कुछ डिफरेंट एक्सपीरियंस भी होगा. कुछ मास, हर तरह का मास एक जैसा बिहेव नहीं करता. कुछ masses ऐसे होते हैं जो ऑन इंडक्शन दे कॉज कार्डियक कोलैप्स, और ऐसे भी masses होते हैं. कुछ masses ऐसे होते हैं जिनको कि आप कर लेते हैं, लेकिन प्रेफरेबल चॉइस यही है कि उनकी स्पॉन्टेनियस ब्रीदिंग प्रिजर्व रखी जाए. जी.
And I can't get, they should not be misconceiving whatever you're saying. And mediastinal masses, wherever they are, they have to be done. Relation एक ज़माने में था.
जी.
But as you're talking tertiary thing and everything,
जी.
then it has to be done fiber optically.
Exactly.
One. In your experience, have you ever tried refusing a cardiothoracic surgeon कि यार ये मैं इसको intubate नहीं कर सकूंगा, और ये not only it's a challenge regarding difficult to ventilate, but difficult to intubate है ही, but ये ventilate भी नहीं होते. One.
जी बिल्कुल, असल मसला यही है.
So in your experience, have you ever tried?
So कुछ केसेस में तो एक, मैं अब थोड़ा सा लंबा हो जाएगा, एक यही इसी तरह का एक थायराइड जो कि retrosternal
Faisal, I'm really sorry, but we
जी,
are running short of
exactly,
time, so we need to move on.
So yes, there are few cases जहाँ पे कार्डियक सर्जन ने खुद कहा मुझे कि इस पेशेंट को बेहोश नहीं करना है, इसका मैच जो है ना वो कर देगा, तो इसलिए आपने जो है ना इसको अवेक इंटूबेट करना है. मैं आई डोंट डू थोरैसिक मच क्योंकि मैं ENT करता हूँ, बट डेफिनेटली मैसेजेस ये कि आपने उसको mediastinal masses को बहुत selectively, otherwise it should be awake intubated. Only awake.
Thanks.
Thanks very much. For the last time, Faisal, thanks very much.
Our next speaker is Mohammad Faisal Khan. He is assistant professor and consultant, section head critical care, or chair hospital resuscitation committee, Department of Anesthesiology, Aga Khan University. He'll talk about personalized mechanical ventilation.
Assalamualaikum. Good morning, everyone. First of all, I would like to thank the organizing team here, Dr. Saad, Ehsan, for inviting me. And of course, I'm really feel honored to be here. I understand, the airway is a very touchy for anesthesiologists, but I'll try to move from airway to the mechanical ventilation. And also, this is one of the touchy topic for the anesthesiologist as well. So when I was making my presentation, I was just thinking, so where should I start and move my notion toward the personalized mechanical ventilation, which was my topic here. So I thought this is the nice, the Hippocratic statement about it's far more important to know what the disease has than what the disease the person has. So we need to, that's the thing that we need to individualize the thing. So my talk will try to focus on intraoperative mechanical ventilation, and I will change the subject toward the ARDS because most of the concept usually to the intraoperative mechanical ventilation regarding the personalized comes from the ARDS network studies and all these. So regarding the definition, the personalized medicine is the tailoring of medical treatment to the individual characteristics, need, and preferences of the patient during all stages of care, prevention, diagnosis, treatment, and follow-up of each patient. The FDA and all these things come from the medicine, so we talk about the right patient with the right drug at the right dose at the right time. But the first line is very much important because I think it's near to us, tailoring of the medical treatment to the individual characteristics. So if we follow this statement, then of course we can think about individualization of the mechanical ventilation. And when I put this line and search the Google, so I got this image. And I think that the tailor knows the best that how to individualize the clothing as per the person's requirement, proper size, proper adjustments, and all these things. So if we follow this, then of course it means that not each patient is similar. The things are pretty much different in terms of mechanical ventilation. So my context is that the control positive ventilation is required in many surgical interventions under general anesthesia, very much part and parcel. But the risk of the mechanical ventilation has a wide range from 1 to 23%. And we talk about the post-operative complications. It also has a very wide range from atelectasis to the pneumonia as well. And this pneumonia can turn up to the complication of that. So, it has a risk of about 75%. When I try to, read the literature, if someone who got the infection or the complication of the positive pressure mechanical ventilations, usually it takes around 6 weeks to come to the normal stage or the pre-morbid situations. So why we are worried about why are we talking about the post-operative complications and the typically the respiratory complications, because we all understand the mechanical ventilation has a wide range of I must say the side effects or the effects regarding the volume trauma, atelect trauma, the barotrauma, and the biotrauma. And of course, this is not very much rarely commonly seen the patient ventilator asynchrony, because this is commonly seen in the ICU, and the cardiac stability as well, because so these two are very much related to the ICU. Those who do, they know much better than me rather, but these three things on the right column is very much relevant. And why this happening? Because we know all these patients in the OR is sedated, they are paralyzed, and the positive pressure effects, which usually changes the gas exchange and the inferior gas distribution and the diaphragmatic weakness. And when your patient is supine, the diaphragm goes up, and it leads to a lot of ventral atelectasis and the VQ mismatches. And again, I'm just trying to build up my notion on that. We all have learned in our trainees that the high ventilations, the high tidal volume, it needs because it improves the oxygenation. And every patient, has a different opening airway pressures. So we need to give a high tidal volume, more than 10 ml per kg. This is one of the common thing. We used to do it as well in the current situation as well. But what about the low ventilation, the low tidal ventilation? And as I mentioned earlier, that most of the common data comes from the ARDS. But we also know that the open lung approach, where you give slight PEEP, it improves the atelectasis, and of course also the atelectrauma as well, because it tries to prevent the cyclic injuries that usually happens without PEEP only because of the positive pressure ventilations. What about the PEEP strategies? When I try to search the data, it's very inconsistent in terms of what, the minimum or the high level of PEEP or the appropriate PEEP should be adjusted primarily in the intraoperative settings. So we'll see some literature and, try to build our context to that. And this is a very common diagram. You might have seen it, whenever you try to rate the ARDS, the lung mechanics. So whenever your patient is in supine positions, so it has a different areas of lung. And when, most of the time we are interested in the opening pressures, and we all know that the upper part of the lung is very much easily opened because of the weight pressure on the lung, and what these areas are usually requires very high pressures to open. And that might be the concept that help us in giving a high tidal volume to our patients, just to try to open this as well. But is this the only thing that we are much interested, or there is something else we need to know to prevent this alveolar collapse and resorption thing, which we usually give with the high oxygen in our patients? So can we prevent it? The most important question is, to me, I don't know the best answer, because as we learned that the safe anesthesia is no anesthesia. So safe to prevent the respiratory complications means you don't go with the mechanical ventilation. But then, if you try to think about the primary prevention, the best thing I believe that the patient require positive pressure. But you need to understand the dynamics of the patient, the disease pattern of the patient. And of course, you need to know the type of surgery as well that might be having some effect when you put the patient on positive pressure. And the secondary thing, if you have decided that you want to intubate and you want to do the positive pressure, then what would be the strategy to go with it? The risk assessment that you might need to do, that your patient would be a high Scott scale score or the lip score, and of course the surgery time, whether it is less than 2 or 3 hours or beyond 2 to 3 hours. What you want to do with that? You want to go with the low tidal ventilations, or you want to set with the PEEP and the flow and the low respiratory rate, because all these have different consequences, and we try to learn with the literature in my next few slides and how these usually create an impact in the patient outcome as well. I'm just trying to focus few things, because if you understand this, of course, it will be helpful to us to know the issues behind the positive pressure. The first thing would be the stress. Whenever you put the patient on the positive pressure, whenever you give the flow, usually it creates a stress on the lung. And we all know that the lung is a very viscoelastic property, and out of the lung there is a thorax which has a bit rigid structure as compared to the lung. So whenever we give a positive flow, it gives a lot of stress to the lung, and this stress usually leads to the barotrauma. And that is why the people are talking about the driving pressure, that how you try to keep this stress to the lung so that you can try to maintain the driving pressures. And there's a lot of papers you can think, you must see that the people are talking in the intraoperative as well, that would be, the normal lung or the disease lung, because we all know that this is a normal lung, the positive pressure may not affect anything. But but we need to know that whenever you give a high positive pressure, it gives a lot of stress to the alveoli and the parenchyma. The next important thing is the strain. So whenever you give a high flow, it puts a lot of strain to the alveoli. The strain mean the morphological distortion, and so people you're talking about how we measure it, because the stress you can easily measure with the high pressures at the end of the parenchyma, but the strain usually it's a calculated version, or rather you go with some research things. But the basic formula of the strain is tidal volume divided by the functional residual capacity, and the functional residual capacity needs a few things to measure, like end expiratory lung volume. And this is the young model of the lung, where the strain is very much, the stress is very much linked with the strain and the elastance. Last but not the least thing is the mechanical power. We all know the law of the Newtons, the other laws, that the potential energy to the kinetic energy. So when you give a high flow and open the alveoli, it needs energy, and the energy usually turn into the heat, and the heat dissipations lead a lot of inflammation, and it can lead to sort of the biotrauma. Not really in the first few hours, but it can develop in the next 24 hours as well. But it all depends the lung types as well, the normal versus the healthy versus the abnormal lung. So the role of the lung protective mechanical ventilation, the practice of the lung protective mechanical ventilation, the OR is derived from, as I mentioned earlier, and the prophylactic use of lung protective mechanical ventilation in both thoracic and abdominal surgery is required. High quality evidence, and what the evidences are, I just tried to go through with that. This is one of the study which is not new. It's published in 2010 by the Mayo Group in USA. It's published in BJ. And the number of patients are very much low. It's about only 40 patients divided into the control but the intervention group. And what they in the one group they give no PEEP. They ventilated with 12 ml per kg, and in the other group they ventilated with the 8 ml per kg with the 12 of PEEP. It's very much high. And what they showed in here, that it improves the PO2 FiO2 ratio, the PSCO2 is better, and the resistance got better, and the compliance got better in the intervention group. But the intervention group presented with a lot of hypotension, but they concluded in their paper that, of course, a lung recruitment strategy in elderly patients is well tolerated and improves the intraoperative oxygenation and lung mechanics during the laparotomy. And the good thing in this paper is, well, in 2010, they also measure the inflammatory markers like IL-1 and TNF-alpha. And in the intervention group, the numbers are pretty low as compared to the control group. This is one of the trial. You might have read it, the IMPROVE trial, published in 2010, 2013 in NEJM. It's done by the French intensive care group, French anesthesiologists, and they showed the lung protective mechanical ventilation has the better effect as compared to the non-protective ventilation. So here they are talking about the lung protective mechanical ventilation. They're talking about the low tidal volume. But if you go and see the paper, again in the control group, there was a no PEEP, and they were ventilated with 10 ml per kg of the volume. But in the intervention group, the patient have a very high PEEP of around 12 with a 6 to 8 ml per kg. And this is one of the controversies that people are discussing, that whether this is a true group, true intervention on, and comparison of PEEP versus no PEEP. So these two people are very much highlighting about the role of PEEP rather than talking about the positive pressure and tidal volume, that if you give the PEEP, if you don't give the PEEP, it has some consequences. And they can see it in, the respiratory the role of the NIV requirement is less in the intervention group. One of the trial published in Lancet in 2014, the Provillo trial, and they also compared the two groups with 900 number of patients, and they showed, of course, it does not provide any much benefit. But in this study, the tidal volume is low in both the group, like 8 ml per kg. And in the control group, the patient have been ventilated with less than 2 PEEP, and the intervention group, the patient have been ventilated with the 12 of PEEP. Here I'm just talking about another trial which is published on the JAMA. And here again, they have mentioned that the lung protective mechanical ventilation with the apply of PEEP has not much value. But here, in both the group, they have given a equal PEEP of 5 centimeter of water, the control and the intervention. And they're just working on the low tidal volume. So the low tidal volume might be not much role as compared to the PEEP and prevention of the respiratory complications. So intraoperative, this is the data from the database, and it's just showing the trend, because most of the studies come in 2014, 13, 10, and this is the data comes in 2015. And just check the anesthesiologist practice, and the people are still ventilating with 10 ml per kg of volume, but the counts slightly decreased for 8 ml. The most important thing here is that the practice of PEEP during the intraoperative has much, the practice has increased. So these few papers dealt with the idea that the PEEP might be effective in lung protective mechanical ventilation and prevention of the postoperative complication. I'm just quoting here the meta-analysis regarding the improved ventilation strategies on pulmonary and cardiovascular complications. I'm just, here they've talked about the risk of postoperative complications. So the risk of the odds of the postoperative complications in lung protective mechanical ventilation, when you give a PEEP of around 4 to 5 centimeter of water, have some effect. So talking about the mechanical power, and as I mentioned earlier, the people are now discussing the mechanical power, the heat energy, and this is the database of the 200,000 patients, elective non-cardiac and patients, and they have calculated the mechanical power with the respiratory rate and the tidal volume and the positive pressure effects, and they found that the patient experiencing reintubations within 7 days, those who have a high mechanical power of more than 7 joules per minute, and this is not a much complicated formula, but this paper highlights that if you ventilate the patient for more than 10 of respiratory rate, like 15 or 16, the odds of getting the biotrauma and the respiratory complications are a bit higher. Like if the factor is around 1.31, the risk of complication is 34%. So this is one of the new thought that we usually forget the role of the respiratory rate, because the rate here is a major factor. And this is the data about the intubations and the non-intubations. And when you go with the durations of positive pressure ventilation with the higher rate, the odds get increased. This trial published in 2019, the IPROF trial, and they divided the patient into 4 groups: the open lung approach with individualized CPAP, open lung approach with the CPAP, standard approach with the CPAP, and the standard approach with the oxygen. And they have mentioned all the patients from ASA1 to ASA4 at Scott scale, higher duration of surgeries. Laparoscopic surgery was also included with that. But this paper did not found any difference in terms of the low tidal volume, but the PEEP would remains normal in that. And then this is the one of the people that who develop the 4 groups and measure the outcome with that. So they have concluded with that, and then the patient who have a major abdominal surgery, the different preoperative open lung approaches tested in the study did not reduce the risk of positive pressure complications. But here, if you see these two lines, the upper line and the lower line, which is the OLA ICPAP and the standard approach with the oxygen, if you compare with these two, it seems like that the OLA approach with the ICPAP slightly improve the risk of complications as compared to the standard approach. And the standard approach means that you ventilate with the with a tidal volume of 6 ml per kg with a PEEP of 5, but no recruitment here they have mentioned about. So I'm just talking about the role of PEEP here, the individualized positive and expiratory pressure on postoperative atelectasis in patient with obesity. And of course, if you lower the tidal volume of 6 ml per kg, here they try to measure the dynamic compliance of the patients. Mostly the patients are the laparoscopic surgical patients, and they individualize that, okay, one group would be the 6 ml per kg, PEEP of 8, the other group would be 6 ml per kg, but their PEEP would be individualized on the basis of the dynamic compliance. So that showed that it would not provide any much benefit in the risk of positive pressure complications, but the oxygen things and the PaO to FiO2 ratio gets better in the first few minutes in the perioperative period, but the post-op period it remains same, nothing much change. So if I have a time, I would go with that, but so I just touch few slides about the ARDS on the intraoperative ventilations. We all know about this paragraph, the picture they talk about it's 2000 and I think 3 and 4, it's 2000 when I was a trainee at the time. So if ARDS is typical, the treatment is typical. But if ARDS is not typical, the treatment is not typical. And we talk and you know one side doesn't, and of course there are many factors regarding the disease pattern, the focal versus non-focal ARDS. And I'm just skipping this, but I wanted to show you one slide on that. That you know the ARDS. We talked about the subphenotypes. The phenotypes mean the hypoinflammatory and the hyperinflammatory, and we have learned it a lot in the COVID diseases. So these two phenotypes, the subphenotype 1 means the hypoinflammatory, and the subphenotype 2 is the hyperinflammatory. And you see these are all in the inflammatory markers, which is very much high in the subphenotype 2 group. And when you see the outcome data of these subphenotype 1 and 2, the mortality is very much comparable. It's very much high in the inflammatory group markers, the inflammatory one, and they also worked on the strategies of the high versus low fluid, the conservative and the liberal approach. The subphenotype 1 group, the conservative approach is better, but in the subphenotype 2 group, which is a hyperinflammatory, the liberal fluid strategy gets, is better on that. So I just wanted to conclude. I know that I've skipped few slides, but I realize I'm not giving you the perfect answer. But the literature is very much mixed, especially for the intraoperative mechanical ventilations. But what I can say at the time that the use of PEEP is better in the operating suite. Personalized mechanical ventilation can influence the incidence of postoperative pulmonary and cardiovascular complications. However, the optimal ventilatory strategy for OR remains unclear. But in ARDS, it's pretty much clear now. But we all know that every patient is different mechanism of disease operatives in different patients, different responses to treatment as well, as I just showed the hyperinflammatory versus the hypoinflammatory. And these are really matters on the outcome of the patients. So assigning the maximum control to patient may maximize the personalization. So this is the last slide of mine. Thank you so much for listening. I know you are in the driving seat, so I just try to control myself and finish.
That's fine. I think in the interest of time, we'll take questions in the end. So thank you very much, Dr. Faisal. Thank you. So our next speaker is Dr. Asad Latif. Dr. Asad completed his residency from Khan University, his residency in anesthesia from US, followed by adult critical care fellowship from Johns Hopkins. He also did his master's in public health from the same institution. Currently, Dr. Asad Latif is chair of the Department of Anesthesia, Khan University Hospital, and his interest lies in improving patient safety and quality, health system strengthening, and particularly in the developing countries. Dr. Asad Latif. He's going to talk about quality in anesthesia, maintaining quality during high-risk surgery.
Thank you, Dr. Hassan, and thank you to Shaukat Khanum for inviting me to talk. This will work at all. Fantastic. So, unlike the last two speakers who had very nice technical presentations for the anesthesiologist in clinical practice, I'm going to be taking a little bit of a step back and leaning on my public health and capacity development background and share some experiences along the way. Here are my disclosures. I have done work, as Dr. Hassan mentioned, in quality improvement and been recipient of multiple grants, but fortunately, no current financial disclosures. We're going to talk about a few things. The importance of quality in anesthesia and perioperative care, challenges in quality of anesthesia care, the current state in LMICs in particular, and then I'm going to try and, usually these quality talks talk about what the issues are. I'm going to try and propose a framework to move forward for us as a country and as institutions. So, starts off with a question. How many of you believe that your hospital is safe? That you would want your loved one to be taken care of in your hospital itself? Any takers? Oh, my apologies. The wrong button got pressed. Can you say with 100% certainty that you do everything that you can or should on a daily basis? What do you think that percentage is? Yes, fantastic. And it is. People have studied this. This is an oldie but a goodie. This slide is from, was published many years ago, and this was a study by the RAND Corporation. And what they looked at is for cases with best practices, right? Things like sepsis, in which you knew what to do, got consensus, what are the things that should happen, when they should happen, and they actually went and studied in a hospital to see how often does it actually happen. Turns out, even in the US, and this was a while ago, it happens about 50% of the time. And this isn't just what should happen, but when it should happen, because timing is very important in medicine, especially in anesthesia and critical care. So how do these errors happen? Well, I postulate that this is really because of variability in practice. And there's a lot of science on this. The reasons for variability in practice are multifold, and it's often because of a lack of multidisciplinary engagement. We don't know what we're doing. We don't communicate it well. We don't communicate the importance of it well. Some confusion regarding the practice. Dr. Faisal just was talking about ventilation in the OR and the various strategies that are employed. I can guarantee you, I have 38 faculty members. I have 21 ORs. Every single one is going to be employing a slightly different approach to ventilation. I know plenty of people. One thing that has come across in intraoperative ventilation, seems like PEEP is important. Lower tidal volumes compared to higher tidal volumes are probably better. But how many people apply PEEP in the OR each and every day? I know I do. Sin does. This is the minority out of many anesthesiologists here. And I can guarantee you in my group also, the majority do not apply PEEP on a regular basis. So there's confusion regarding practice because we just don't have that. Often there's workflow issues, practical things. One common issue that happens in anesthesia is narcotic reconciliation. Where I was in the US, narcotic reconciliation was a strong emphasis. Every day the paper was filled out. How strong is narcotic reconciliation at your institution? I can guarantee you at Ahan, we fulfill the draft requirements and give them the duly filled out piece of paper at the end of every year. I can also guarantee you that about 40% of my residents do not fill it out on a daily basis. This is just the way it is because of practical workflow issues. Ek case aa raha hai, dusre ko lekar aana hai. There's one window for pharmacy and there's 21 wars to start at the same time. There's a rush. Ek aapne le liya, dusre nahi liya. Chalo, agle mein le lenge. Things happen. often there's a lack of required resources. And I'm not just talking about physical resources, which is a common thing that we talk about. It's human resources. Time is a resource. But not everything's dependent on just that. But the strongest one, and this is what research shows, strongest one is provider beliefs and practices. We do not have a uniform approach or belief. Convincing people that something needs to be done is very difficult. So what we really need is to view healthcare. We view healthcare as science, but we very often don't view the delivery of healthcare as a science. So, importance of perioperative QI programs. Now, this is where it gets a little bit tricky, right? Because often in anesthesia, we think, oh, this is a surgical issue versus an anesthesia issue. But ultimately, this is that ऐसी शादी है जिसमें तलाक नहीं हो सकती है, surgery anesthesia की. Surgical care and the burden of surgery is tremendous, accounts for about up to a third of the global burden of disease. There's millions of people who require surgery on an annual basis. And so therefore, there's a growing recognition that there is need for perioperative QI programs in LMIC, especially in anesthesia, and the benefits are manifold. I'll get into this a little bit more, but the enhanced patient safety, improved surgical outcomes, and this is often where we might lack the drive, because we talk about anesthesia outcomes, and anesthesia-specific mortality is low. And this is what we measure: how many people survive an anesthetic and how much they make it out. And that generally runs around 0.1 in 100,000 is the generally quoted number for anesthesia complications. But anesthesia management impacts many perioperative conditions. And I would hazard to say most people will agree that intraoperative management has been shown to affect things like post-op acute renal failure, perioperative MIs, perioperative strokes, and surgical site infections. So it is an anesthesia problem, not just a surgery problem, and anesthesia quality or maintaining quality of care in anesthesia and QI programs anesthesia will help all of this and ultimately help the patient, which is the center of this discussion. Not whether it's an anesthesia or surgery issue, but whether it's a patient issue. So implementing QI programs has been associated with many things, right? Reductions in complications. SSIs have had a tremendous impact, things that have been studied. And one of the most important things in SSI prevention has been intraoperative homeostasis in terms of temperature, glucose control, and pre-op antibiotics. And that squarely falls under the domain of anesthesia in most places. Financial savings. And just in the US, where this has been the most studied, under perioperative QI programs led by the ASA, as well as the American College of Surgery, a major surgical complication accounts for $12,000 in extra costs, and those are prevented. And ultimately, better health system efficiency, reductions of length of stay and readmissions, and improved patient satisfaction has been well documented with better pre-op anesthesia care. So what are the key components of quality anesthesia when you think of just the anesthesia? There's, naturally, we divide into 3 phases: the pre-op assessment and evaluation, where high quality anesthesia can help identify potential risks ahead of time and optimize the patient's condition so clinical complications don't happen. But again, many of these don't affect what happens in the OR. We'll get them through the case. And I'll guarantee you 99% of anesthesiologists are confident, 99.9% are confident in their ability to get the patient out of the room. Job well done. And that's where it ends. But that is not where it ends for the patient, and therefore for us. So anything we do to identify risks for the perioperative period is critical. Monitoring during anesthesia, again, we're experts in using continuous data from specialized instruments. We have A-lines, we have the wealth of data that we use and process on a minute-to-minute basis. And how efficiently we do it and how well we record it really helps determine the quality of anesthesia, right? Intraoperatively, for example, what is the ASA standard for monitoring? It should be for documentation of monitoring, right? It's continuous, should be documented every 5 minutes. Who documents every 5 minutes? This is the benchmark set by our societies, yet the majority of people did not raise their hands. I know in my institution, the residents आके बोलते हैं, sir, आप ही 5 मिनट में कराते हैं, बाकी सब तो 10 मिनट पे लिखा देते हैं. And when I go into rooms, we document at the end of a case very frequently. I see blank charts when I step into rooms. How can we ensure that something happened or something didn't happen? So we're paying attention. Are you? Are we really able to? If we didn't document, it didn't happen. And then, of course, post-op care and recovery. Then one of the key component of quality in anesthesia, the historic pre-op, intra-op, and post-op, the ho gaya. Once they leave the recovery room, we often forget things, but things that we don't actually enumerate is teamwork, team communication, collaboration. This is probably the one thing that has been shown to improve outcomes. Who has heard of the WHO Safe Surgical Checklist? I would hope everybody has. But that is one of the best tools and has been shown to reduce perioperative morbidity and mortality by over 40%. If this was a medication that improved outcomes by 40%, this would have gotten a Nobel Prize. But we don't use it. And the basis of that whole tool is standardized communication and assignment of responsibility. That's all it is. Delegating responsibility and collaboration, forcing it, and communication. And just that improves outcomes by 40%. Atul Gawande should have won a Nobel Prize for that. Importance of quality in anesthesia, I hope I don't have to convince any of you. It helps with patient safety and comfort, in effective pain management. We've spoken a little bit about reduction in morbidity in many cases, and there's well-proven studies about SSI reductions, perioperative adverse events, and ultimately the effect on surgical outcomes, right? Anesthesia care has been linked to improvements in SSIs, post-op leaks, fluid management is a great topic of discussion these days. Respiratory complications, as Dr. Faisal mentioned, all of these things. However, many of these complications happen after the patient leaves the OR, after they go to the hospital, and after they leave our sight and mind. So what are the challenges for anesthesia quality in LMICs? The first, I postulate, is really lack of standards. The challenge is it's hard to know what the standards are. What are the quality indicators for anesthesia? I looked into this. There are some by a bunch of societies. The American Society has one, the British, a bunch of Central European between the Germans, Australians, the Austrians, the Swiss. Guess what? All of the indicators are different. The WFSA, a guiding body for World Federation Societies of Anesthesia, has a completely set of indicators from everybody else, and theirs are focused more on human resource and health workforce, not on intraoperative quality. So we're unsure about what to measure and how, and the protocols and guidelines required, right? Next is shortage of trained healthcare professionals. Since I've come to Pakistan 4 years ago, I'm impressed by the number of different types of anesthesia degrees that I'm finding. There's a huge lack in the rural areas, of course, but between CPSP, FCPS, MCPS, MD, anesthesia diplomas, just about 5 things that I keep hearing about, learn something new every time I go. So lack of standardization, and even then we're short of healthcare professionals in anesthesia, right? Inadequate infrastructure and equipment, I don't need to talk about that. Everybody's facing a shortage. Limited financial resources, of course. But furthermore, we have limited access to technology and data management systems. How many people still use a paper chart for intraoperative care? Wow, even our British colleagues, fantastic. Really? Okay. But the standard in most places in the West, like in the US, they've moved to intraoperative electronic charting. Inshallah, hopefully Akhan will be moving there in about end of 2025. So we'll see how that will help our QA programs, right? But data really is the basis of this. There's also limited research awareness, capacity, or dissemination of research in quality, because we don't think it's a real issue. And finally, there are cultural and organizational barriers for unifying under quality. And I'll talk about this a little bit. So current state of anesthesia QA and LMICs, like I mentioned, limited recognition of need, limited implementation, and we face significant barriers. This leads to disparities in the quality of care that we provide. And this happens between LMICs and HICs and high-income countries, but I'm pretty sure this happens within the country also, right? The standards at Shaukat Khanum and at Khan, I challenge anybody to find the similar standards in the vast majority of places where people get healthcare, right? between us, we probably do about 35,000 cases a year. We do about 20, you probably do about 10, 15. In Pakistan, there's more than 1 million surgeries performed a year. What do you think the standards are for those other people? So there are just definite disparities in quality of care within our institutions, but more so within our countries. But it's not all lost. There's increasing recognition, at least at the policymaker level, that there is a need for anesthesia QI in LMICs. And they're isolated initiatives with promise. For example, how many of you knew that Pakistan actually has a national surgical vision plan which incorporates anesthesia care, workforce development, as well as standardization? So they passed it. It's 1920 to 2025. But there is talk of this starting. We often just don't hear it in our societies. I don't know if PSA is on board with this, but anesthesia helped document this. That last part about teamwork, we're talking about how teamwork is an issue. Well, how many of you think teamwork is an issue? There's some fascinating data about teamwork being an issue. So this was a study that was done by colleagues of mine at Johns Hopkins. And there's a very simple study. What they did is they went to doctors and nurses who work in the same area and asked them, do you think you work as a team? Do you communicate about everything you need? And unsurprisingly, the doctors said, yes, we have fantastic teamwork. When I tell somebody to do something, it happens. About 80 to 90%. This is the area we're interested in, the OR. However, when you talk to the recipients, the nurses, they didn't think teamwork was fantastic. They thought it was about 50%. I'm not heard. I can't tell the doctor what I want to do. This is in a mature healthcare system like the US. If we did this study in Pakistan, and I look forward to trying, what do you think the disconnect would be? I think that the difference would be far more extreme, right? And this is one of the pillars of improvement. So let's get into how we improve, right? This is a historic way of improving, the IHI model, the PDSA cycle we're all familiar with. The problem with this really is that this focuses on technical interventions. And we know that technical interventions by themselves do not work. This is a slide over time of wrong site surgery that the JCIA puts out. And as you know, this is a bad thing. For years and years, what the JCI did is, don't do it. Don't do wrong site surgery, danto, tanda maro, jo bhi karna hai, nahi karo. What do you think that resulted in? Over time, rates increased. Because turns out that telling people not to do something does not actually improve results. It actually requires a little bit more than that. So I postulate an approach to improvement. This is a model developed at the Armstrong Institute at Johns Hopkins, which does two things. A, key takeaways, you have to start by measurement. Everything starts with measuring. You can't improve, as Deming said, you can't improve what you can't measure. The next is the technical interventions, which we have around translating evidence, making checklists and stuff. That's great. But it has to run side by side by some sort of intervention to work on people's attitudes, a culture intervention. And that is how you improve, because when both things run side by side. So improving safe care, I'm going to get into an esoteric concept about patient safety and safety culture. But I postulate this is why Shaukat Khanum has such fantastic outcomes for its patients, because the culture at Shaukat Khanum is different. Many of you have worked in other places, and if you haven't, you will. Culture accounts for a lot of this improvement. There are studies that show this, that it takes culture to get the most out of practices, and it's critical to improving that last component, that provider beliefs and practices, right? It's critical to improving briefings and debriefings. There's good literature on this. The WHO Safe Surgical Checklist, which I mentioned earlier, which had a 40% reduction in morbidity and mortality, turns out the vast majority of it was predicted. There was a second study by Weiser, which showed that the safety culture, the institutions that had a better safety culture had better compliance and had greater reduction. And the ones that didn't have a good safety culture didn't actually show a reduction. They showed a reduction across their 8 hospitals, but it was all predicted by the safety culture. This works in the OR. This was a similar model that had a unit-based safety program that made QI teams in ORs to improve their SSI rates. And all they did is, the intervention was to make QI teams in hospitals focusing on SSIs. Everybody knew the guidelines. They just worked with the local people, because the QI teams were made of the local people to improve them. And this showed decreases in SSI. Similarly, this slide shows data from one of the first studies that looked at association between safety culture and outcomes. And this was specifically for that same work that happened before at just Hopkins. Then they did it across multiple hospitals. And they showed that their safety culture score showed the ones who had the lowest rates. The higher the safety culture score, the lower the rates and the better the compliance. So my last bit is really about a run through about what we should do about it, right? We do need to improve and need to develop a successful QI program in anesthesia. The key to that is sixfold. It starts off with a needs assessment and setting goals, because this is where we need to identify our own challenges and gaps rather than just copy the programs that the US or UK might have. We need to do what works for us. And this is where you develop the need, develop the basis for how much of an issue this is, and engage the stakeholders to understand their perspectives and priorities. The next, and this is where we often fall short, is we need to engage, focus on the leadership and governance of the importance of QI. This is actually a slide of work that we did at Ahan, and this was from another context, looking at reducing infections in the ICU. This was also using a team-based model. We made QI teams. And what this showed was we had 3 units and the different rates of improvement. The unit with the most significant improvement, and these teams were based off executives, physicians, nurses, and the QI expert. The team that actually had a significant improvement was the one which had across the board good attendance. If even one of these groups was missing, had below 85% attendance, especially the executives, those teams did not have significant improvements in their infection rates. So the team stakeholder participation was key. Of course, capacity building and training, we have to focus on QI specifically in anesthesia, teaching people about how to measure and improve quality. And our training focuses very much on the clinical components. All of you become fantastic anesthesiologists, but anesthesiologists are the health systems drivers for change, in my experience. So we probably need to incorporate focused and dedicated QI development in our training. And then, of course, data collection analysis is key. We need to have robust data collection systems. At Aachen, we're developing a perioperative registry based on electronic data that we have. I would actually venture to say that we should do this at a multi-institutional level. This is what has made the difference in the US, for example, the AQI project, NACOR that the ASA has started, where people are pooling their outcomes. And the MPOG study, I don't know, Michigan Perioperative Outcomes Group is something that started in Michigan, but now has multiple academic institutions feeding into it, and it comes from EPIC. So this is actually a big multidisciplinary focus, and I think this is where we, as single institutions and ultimately as a society, can focus on in the future. You can't improve quality if you can't measure it, and to measure quality, you need robust and valid data. And then, this is really the current state of theater registries. This is what we have. This is outside of Shaukat Khanum, and most places in Pakistan, I think you'd be lucky to even get this to find out what the OR outcomes are. Once a patient's left the OR, they've left the OR. And we really need to work on developing a registry is my postulate. And then use that registry to have focused QI interventions. Be targeted, focus on a specific problem. I suggest we even start focusing on the WHO Safe Surgical Checklist. We know that this works. We know that this can have an impact. And we know that we don't do it very well. And then the final point that I have is all of this work needs to be done through collaborations and partnerships. It can't be a single institution, a single person, a single unit, a single OR. This ultimately needs to be multidisciplinary collaborations within our institutions. We can't do it without the surgeons or the nurses, and they can't do it without us. But more importantly, we can't do it without each other. So I look forward to collaborating with Shaukat Khanum and others on developing these sort of things. And this is possible. This has happened in multiple countries. I've led multiple large-scale QI projects for ICU care. There's no reason why we can't do it for OR care. So with that, I will leave you, because ultimately, with these 2 quotes, it is a small group of people that lead change. It isn't the government. Nobody's going to come and rescue us. There's no aid package coming. And we really must learn from the mistakes of others, especially our colleagues in the West, because we just can't live long enough to do it on our own. So with that, thank you very much, and sorry for going over time.
Thanks very much, Dr. Asad. A very enlightened talk on quality improvement. Can I have a snapshot election as well? Not really election. Those who are doctors, can you raise your hands, please, including me? So those who believe that there is teamwork in our system wherever we work, can we keep raising our hands? Who believe that we've got teamwork in our areas of work? Okay, so again, 90%, I would say. So all those who are not doctors, can you all raise your hands, please? Okay, now keep your hands raised. So those who think that they do not have teamwork, put your hand down. जिनका ख्याल है teamwork नहीं है, अपने हाथ नीचे कर लें. Okay, fine. So maybe John Hopkins can learn a little bit from us. Fine. Thanks very much, everyone. So we will move on to panel discussion. If there's any questions for Dr. Asad. Any questions for Dr. Asad? No. Okay, so we'll move on to panel discussion. Okay, Mansoor has a question.
Assalamu alaikum.
Oh.
My name is Abdullah. I'm currently working in anesthesia technician Shaukat Khanum Trust. My question is, how can we educate our community to better understand anesthesia? Most of the people are fearful of anesthesia because when patients have issue during surgery under anesthesia or patient die under anesthesia, the people blame to anesthesia team. So, because there is a myth that anesthesia team has given too much anesthesia, which lead to death of the patient. What is the best approach to address this? Thank you.
Good question. I think there's lots of anesthesiologists here. This is not something that only I can answer. I open the floor to others. My take on this, this is something that I've noticed in Pakistan since I came back, but it is true everywhere. This is an education problem and a perception problem, right? Ke hum log, and also fear. Where does fear come from? Fear comes from fear of the unknown. Anesthesia ne ek tarah se, I'm sorry, others can disagree with me if they want. It's often under a shroud. Thoda sa dhaka chupa hota hai, pata nahi andar jata hai, and people are afraid of the sense, not the fear of the unknown and the fear of their loss of control when they go under anesthesia, right? And I'll be honest, anesthesiologists as a profession have not done much to counter that in most low-income countries. In the West, they are very front and center. It's just a part of surgical care, and outcomes have improved. This was true in the West about 40 years ago also. But when they started having their perioperative outcomes, they started publishing it. Anesthesia was actually the one specialty that was specifically mentioned in the Institute of Medicine report in 2001, Quality Chasm, which said that this is the one specialty that has actually got, pardon my French, their stuff organized and actually focus on quality and measure it. So America ke andar aur bahar mulko mein anesthesia mein they were open about their outcomes. They're open on their efforts to improve them and showed that their outcomes are getting better. Unfortunately, humne ye nahi kiya. Surgery ke andar often the surgeons get the glory, and there is a lot of lack of communication and trust between surgeons and stuff. हमारे institution में भी जब कोई surgical complication यार वो anesthesia ने कर दिया. Anesthesia case भी cancel करता है और anesthesia patients का outcome भी खराब करता है. But we started countering that with data. For example, one common perception at AKU was anesthesia, आप लोग बहुत cases cancel करते हैं. एक case, we do 25,000 cases a year. We started keeping track of all the cases that are canceled, what they're canceled for, and what the no-shows are for. Turns out, and then I started putting out a daily report to the surgeons. Turns out out of, we have about 15% no-show or cancellations, about 5% cancellations on the day of surgery, of which 40% are because of the patient, 35% because of the surgeon, and about 5% because of anesthesia reasons. But this helps change the conversation. So we have to lift that shroud up. Apne aap ko zara dikhana padega, and we have to make those conscious efforts like they have in the West. Dr. Hassan?
you pretty much summed it. I'm never worried about the perceptions, what people have. कि जी anesthesia के मुतालिक अगर perception किसी को negative है, तो it's our job is to do a job, and as long as we are doing our job in a professional manner, then it doesn't really matter. What is important for us is that we stick to quality. As long as we are confident in our provision of quality, then I don't think these kind of conjectures matter really. Thanks very much, Dr. Asad. So we will move on to panel discussion.
Moving on to panel discussion. The topic is training new generation of anesthetists. Are traditional methods obsolete? Our participants are Khwaja Kamal Nasir, Faraz Mansoor Saab, and Khalid Samad.
Thank you very much, Dr. Salma and Dr. Ahsan Waqar. Bahut shukriya. Now I would request Dr. Khalid Samad to please take his seat for the panel discussion. Dr. Khalid is a consultant anesthesiologist and associate professor, Department of Anesthesiology, Aga Khan University, Karachi. And he has special interest in cardiothoracic anesthesia, trauma and disaster management and critical care. Thank you very much, sir, for coming. And our second participant is Professor Khwaja Kamal Nasir, is the former professor of critical care and anesthesia from Pakistan Institute of Medical Sciences. He was also one of my teachers during my training in anesthesiology 20 years back. He's presently working in Islamabad Medical and Dental College and establishing a critical care unit there. Thank you very much, sir, for coming. So, a very important topic for the young trainees and for the supervisors as well, how to train the future generation of anesthesiologists. So मेरी कोशिश होगी कि मैं कम से कम बोलूं, वो जो हमारे गेस्ट हैं वो ज्यादा पार्टिसिपेट इसमें जो है वो माइक so we'll keep it simple. So I will start with Dr. Khalid. So Dr. Khalid, what do you think? What is the present situation of the training program in our country? Are you happy?
Assalamualaikum. So basically, when I've started my training, I started working at a government hospital, and mainly what I've seen that there is a lack of communication between the faculty and the training. And in my experience, what I've seen, but it was like in 95, 98. But at that time, I've seen that there is a proper residency program, but I didn't see any training over there. So over a period of time, then I've started and see that people are trying to move toward engaging the resident and trying to create some kind of programs in which there is training and there is they have started interacting. So they basically work on like clinical interaction during their working in the OR, and then there is dedicated teaching sessions, and they started. When I moved to a tertiary care hospital, AKU in 98, there I've seen that there's a structured program, but there has to be a continuous evolution of the programs. It's just not like doing lectures and see that the teacher is giving a lecture and the learners or the residents are just listening to it. But over a period of time, I've seen that now students are like to be more interactive.
Yeah.
They just don't want कि जी के वो teacher जो है वो lecture दे दे और residents की खत्म कर ले. Just like 2 days back, when I was making my presentation, I was sitting with my kid, and I was just practicing for the presentation. So she said, कि अगर आप सिर्फ प्रेजेंटेशन करेंगे तो मैं तो सो जाऊंगी. So those people they want to interact.
Yeah,
The new generation is basically they want, because is now the social media is so strong, and they are continuously interacting. So what I feel that over a period of time that the learner, they want to interact.
yeah, that's right. जो हमारे जो trainees हैं, they want them to be involved in the training program. So Dr. Kamal Nasir, same question from you. I mean, are you happy with the present situation of the training program in the country?
Before I start talking, please don't get offended with my words and whatever. ठीक है, मेरा नाम Dr. Kamal है. I've worked in the position of responsibility for quite a few years. And I'm thankful to Faraz. I'm thankful to Faraz for inviting me. As some, you know, they are very kind to me and they execute a lot of respect. And the point is that at the end, हमारी perception depend करती है कि what are our perceptions. Asim differs with me कि he negates those that think कि जी लोग क्या सोचते हैं. But it is very important कि लोग क्या सोचते हैं. Until and unless we start thinking कि भाई लोग क्या सोचते हैं, उससे पहले फिर हम आगे नहीं चल सकते. And the point is, जैसा आपने मुझे बताया कि present situation क्या है. Present situation, I don't need to tell you. Abid has just said, highlighted कि भाई the communication नहीं है, ये नहीं. We all know the present situation. Years ago, how training was done, what different थी. There were no programs, जिस तरह डॉक्टर साहब ने कहा है, there were no regulating authority. उसने उसके साथ काम किया हो जाता था. So basically, we as a society or doctors or whatever, we have to understand the situation you have, it is dismal. And I, for one, have worked in government sector, and it's not dismal. It is, if there is a word beyond this, I'll like to express that, but I don't have it right now in my vocabulary. People, जो हमारे अपने doctors associates हैं, जो anesthesiologists हैं या doctors हैं who are working in very good financial organizations, उनकी perception बिल्कुल different है. You can't tell a person the horrors of war. You can't describe the horrors of war to a person who has never attended or gone through a war. People don't understand what anesthesia is. Your surgical colleagues don't understand. So there is no teamwork. Let's put it this way.
Yeah, there's lack of awareness.
So, unless we accept that there is none, only then when we can start things. People don't take responsibility. Trainer कहता है कि I don't get trainees. मेरा paradigm shift हुआ था 1976 में. That takes you 50 years or 55 when one of my teachers said, what is a good institution? Definition आपके पास नहीं होगी तो आप नहीं कर सकते, नहीं चल सकते. And I still remember those words in my head, and which pertains to a trainer. What is a good trainer? We all salute ourselves. मैं भी शीशे के आगे खड़े होकर कहता हूँ सबसे अच्छा trainer मैं हूँ. But am I? What is a good trainer? What is a good institution? Is क्या ले रहे हो और क्या निकाल रहे हो? If a trainer thinks कि ऐसे one patient वो उसे 50,000 किए without mortality and starts saying कि बड़ा अच्छा हूँ मैं, या मैंने 5 लड़के FCPS पास करा दिए हैं या post graduate, but what about the boys जिसको तुमने नहीं किया, जो average थे? So the idea is the trainer should define his role. Average को better करना है, poor को average करना है, average को better करना है, और जो अच्छा है वो तो अच्छा हो ही गई. So similarly, मेरे लिए मतलब, I mean, how this Abid has talked about standards, and that is very good, and that is what we have to achieve. And that we can't achieve until and unless we have a standard in our own head. As a trainer, as a trainee, क्या roles हैं हमारे? मेरे लिए training हमेशा, I have always aspired to bigger ideas. That's why I have not been a successful person, you know, as you people know. You see, training comprises many things. It's not कि आप आए हो, आपने सीधा दे दिया और आपने करके चले गए हो. A trainee or trainer का relationship बड़ा अजीब है. Training, I'll talk in concepts now. Training is basically, आप jargon तो उसको बता देते हो कि ABC क्या है. but it also includes education. Trainer has to know what education is. Education has come through a long time, you know, the word itself. 1985 में इसकी कोई definition थी, 1815 में कोई और definition थी. How I aspire, how I see education is different. I want that boy to know ABC, जो उससे communicate कर सके, which are words, syntax बनाए, जो भी हो. But most importantly, I should stimulate him to think. If he's not thinking, then I'm failing. And if he's thinking, then I have to tell him that he has to be patient. So patient thinking mind can analyze the problem. How many of us in Pakistan are, as a general society, as people, patient? आप लाइन में खड़े हुए हो, आपकी लाइन को कट करेगा. That just depicts our character, you know, basically. So that's an issue. Teaching. अच्छा, now what is teaching? आप आते हो, lecture देते हो, एक अच्छा lecture. अच्छा, by the way, anybody can interject anytime. I don't mind that.
You guys can participate.
Teaching क्या है? Oh, what is teaching? Teaching is you come here, give a lecture, nobody understands. जिस तरह आपने कहा, मैं तो सो जाऊंगी, and that is true. And you think you deliver a very good lecture, you know, you articulate rhetorically, आपने बातें की हैं.
Sure.
And that's one famous personality that I read about, and he said, it's not what you are teaching, it's how you are teaching. कितना passion है आपका उसमें, कितनी importance दे रहे हो. How the trainee should know कि आप कितने involved हो अपने profession के साथ. I am a vulgar man, I am a obscene man, but my profession is not. Similarly, so training जो है वो constitute करती है teaching, education, and then learning. If your trainee is not learning, then all of the above two things they're not working. There's something wrong. So, अब वो learning का फिर वो जैसा मैं कहता था यार मेरे ट्रेनीज अच्छे नहीं हैं, वो फिर ट्रेनीज को आपने ऊपर करना है, आगे लेकर आना है. But that has to be, you see, learning किस तरह होनी है. अच्छा, I am also learning. Trainers usually think they know all, you know, but the more I did anesthesia, the more I worked, the more I became, you see, ignorant. मुझे पता चलने लगा कि यार मुझे तो कुछ भी नहीं आता. And those people who have worked with me, I've always been full of doubt about all the activity. So these are all concepts, and we as trainers, I dare say that we have to go into these definitions and we have to sort it out. Those people who are working in private institutions, छोटी clinics पे जाते हैं, anesthetists जो हैं, उनकी perception बिल्कुल totally different है. आप उधर तक नहीं गए, मैं I have been there, जहाँ पे 20 gauge cannula सिर्फ लगा हुआ और spinal C-section हो रहा है. And I've got horrific stories because I've been working in intensive care, and when I used to tell these doctor colleagues that I am the spy, I know what you do because anesthesia जो है एक अजीब specialty है. Your interface is with other doctors. You know their weaknesses. If a person comes in a failing heart and a cardiologist tells you कि इसको epinephrine लगा के या norepinephrine लगा के blood pressure ऊपर कर, तो you know कि he has no idea about afterload. Those guys who can't understand this aspect, but there are some who will be understanding this thing what I'm saying. अगर एक आपको आके thoracic surgery की बात कर रहे थे, ये postponement की, कि अगर आपकी ट्रेकिया जो है बैठी हुई है और the message has to be कि इसको मत करो, ये नीचे है, ये हम वेंटिलेट भी नहीं कर सकेंगे, ट्रेकियोस्टमी भी इसमें मदद नहीं करेगी. मुझे सर्जन ट्रेकियोस्टमी कर देते, ट्रेकियोस्टमी डजंट हेल्प. बट देयर इज नो, वो कहता है कि आपको काम नहीं आता. उनकी परसेप्शन जो है नीचे बैठे हुए हैं, वो आई हैव कम क्रॉस सेक्शन ऑफ एनेस्थेटिस्ट, उसे यही हमारा काम ये सर्जन के साथ चलता है, हम क्या करें. दो हाँ प्लीज, हाँ बोले.
Mike, Dr. Asma को mic दे.
So I actually agree with what you are saying. I think both education and training, it's going through a process of evolution.
Yes, yes.
जब हम educational learning की बात करते हैं तो वो start होती है जैसे pedagogy, जहाँ पर spoon feeding होती थी, और अब हम उसके बाद evolve होते होते we talk about the cognition theory and the theory of constructivism, and then we talk about simulation and artificial intelligence. So us process of evolution mein, I think it has really become important that as trainers we are trained as well. जहाँ supervisors, for example, जो supervisors हैं, they need to be trained that how to interact, how to give the feedback. So these are the things we also need to learn as the teachers.
Very good. And this is
Yeah.
exactly what I'm saying. Like in the older years, you know, there was a concept of apprenticeship. 19th century में apprenticeship थी. He knew everything about that guy that he was training. You know, tailor master के साथ बैठा हुआ था, किसी के साथ भी. And he would basically tell the parents कि मुंडा ठीक नहीं, ये लड़का ठीक नहीं है, ये आपका बच्चा ये जो है ये करता नहीं है ठीक. So basically, जैसा आप कह रहे हो evolution, we as trainers, learners, जो trainees हैं, we are all in the process of evolution. And until we accept this, that we are in a process of evolution and there is something more to come, only then when we cross those borders. And I have to quote this philosopher that I read, and I'm really fan of it. वो कहता था कि एक ही question है, what is the truth? Your administrator as Tarka, he wants to generate more money. That is his truth. Surgeon says, I am not concerned about post-op complications. I have just removed that thyroid. Uske baad jo marzi hota rahe. That is his truth. But here is this anesthetist who starts thinking, if the patient opens his eyes and sticks out his tongue, that is good anesthetic. That is his perception. My mother, God bless her soul, she used to do service ventilator se wo karti thi, wo anesthesia deti thi in 71, 72. And the standard was there was no surgical blade in the private clinic and the surgery had to be done. So she had given a spinal to this patient. She sat in a car, went, bought a blade, and the surgery continued. This is a fact. This will come as a news to you. ये पहले था, हाँ बोले, हाँ
जी जी, आई सर.
So, I think because we all have been trained in different areas.
Yes.
Because I just feel that, most of the time we don't know the true training is, because we usually believe that the training means only the clinical aspects. I just trained him putting the lines. So if he's to stick with 10 lines, he is now competent enough. I've just trained him for the intubations. And now I can sit outside the OR because I've been given a chance for 20 intubations and now he's expert. And we usually forgot the other aspect of the training, like non-clinical training. I don't want that he would be like me in intubating, but I want that he would be an honest person. At the end of the training, when he go out, he would be my face in terms of not only the part of intubation, but the professionalism, attitude, his ethics, what about is. So where we are at this time that we are training our people from this aspect regarding maybe just putting only the concept of the clinical part.
Yeah, thank you, sir. Dr. Mansoor, we have Dr. Mansoor Bangashare from NHS. Dr. Mansoor, कुछ आप ऐड करना? Do you want to add anything else? I mean,
जो फैसल खान ने बात की है ना, वो वैसे फैसल खान ये कहना चाह रहे हैं कि जो ट्रेनिंग प्रोग्राम है हमारा, it is limited to some clinical aspect. But basically what I'm saying is that we have a college who guided us to follow certain standard for the training. For example, for a training program anesthesia में, और उन्होंने curriculum पूरा design किया हुआ. So they have made a standardization, and then they guide institution to follow that standard. So now it is the responsibility of that institution to follow the standard. So in different hospitals, जो अच्छे hospitals जैसे हमारा एक hospital इसमें PGB बना, postgraduate education program बनाए हैं. So what they do is they make sure that every residency program follow that standard. And then within that program, they define some kind of system of teaching on job, for example, in OR or education or research. And then they also made sure that the teachers who are teaching, they have some kind of accountability so that we can say that higher ye teacher sahi hai, ye nahi. But it is very important to set a standardization across the institution, because अगर मैं चाहता हूँ कि मैं अच्छा टीचर हूँ, मैं पढ़ा दूँ, इससे जो है ये सिस्टम ठीक नहीं होने वाला. You have to make us some kind of standard across the institution to make sure that everyone is accountable for that.
Very good.
Thank you very much, sir.
Yes.
जी.
शाबाश, very
थोड़ा
good.
सा चेक एंड बैलेंस भी होना चाहिए.
Mic पे आ जाओ.
President has mentioned 40 cases in their logbook. I just signed it.
शाबाश.
I didn't know whether he has done it or not. So, and of course, this all will go to the CPSP, and CPSP would realize that I have, signed it. Might be I have seen it or not. Though there is no check and balance on that part as well. हमारे training
जी.
program में कि हम ये judge कर सकें कि जो काम हो रहा है whether this is a true or untrue.
जी, डॉक्टर एहसन जी कुछ कहना चाहेंगे ऐसे.
So I have a story to share, and
Yeah.
then after that story, just a few statements.
Okay.
So this story goes back to year 1999, March, April 1999. I recently joined anesthesia and
माइक
MCPS training
नजदीक कर लें माइक.
as an MCPS trainee at PIMS. So anesthetized a patient, came out after anesthetizing a patient and came to the coffee room. So anesthesia department's coffee room was an institution in itself, mind you. So we came to that institution, start having a tea or cigarette uske saath. So कमाल साहब नए नए आइलैंड से आए हैं, ये मुझसे पूछते हैं कि तो थिएटर में कौन है. मैं कहा सर वो सिस्टर समीना है, मुझे नाम भी याद है समीना का. तो वो कहते हैं वो अकेला छोड़ा है वो. मैं कहा नहीं सर वो है ना, वो है, वो देख रही है, वो बड़ी अच्छी है सर, वो मुझे तीसरा चौथा महीना एनेस्थीसिया. तो मैं कह रहा हूँ नहीं सर वो बड़ी है, शी इज वेरी कॉम्पिटेंट. तो एक बहस होती है मेरी कमाल साहब के साथ कि क्या मेरा थिएटर में रहना जरूरी है एज एनेस्थेटिस्ट, एनेस्थेटाइज करने के बाद. एंड ही इज ट्राइंग टू कन्विंस मी कि नहीं तुम्हारा रहना जरूरी है, एंड आई एम ट्राइंग टू कन्विंस हिम कि मेरा रहना जरूरी नहीं है, सिस्टर समीना इज वेरी कॉम्पिटेंट. आखिर में कमाल साहब ने अपने स्टाइल में एक जुमला बोला, यार तो नहीं पता गोरा जीत गया है. हमें उस जुमले की कुछ समझ नहीं आई until many years later जब हमने गोरे के साथ काम किया. So the point is that we were unaware.
Yeah.
I think the present day trainee is a lot more aware. This concept that anesthetist has to say in or out is not open to question anymore. It's set in stone. Anesthetist has to be in. Trainee, non-trainee, doesn't matter. Or the rest of the comments that people have given, I agree with. But I think awareness is
very
definitely better.
important. Yeah.
So my cup is half full.
Yeah, डॉक्टर आसमा आप कुछ कहना चाहेंगे? माइक पे आ जाए.
Because I recently had been to a CPSP workshop. So apparently the CPSP is starting a feedback from the trainees for the supervisors. So I think that will be the first step towards
To move forward.
towards that concept that the trainers also need to get a feedback.
Thank you very much. Dr. Mansoor Bangash है हमारे साथ from NHS. So I would request Dr. Mansoor Bangash to say a few words on the current situation of the training program in NHS. Are you happy, sir?
Thank you very much. I've recently become a faculty tutor for intensive care medicine in England as well. So this is a subject area that I'm a little bit familiar with. Obviously in Western developed or mature healthcare systems where there's a lot of resource as well, it's more straightforward in terms of how the training system is. There are curricula, there are competency-based formula with regards to clinical elements, but there's also competency-based elements with regards to softer skills, for example, governance and, for example, team working and your ability to liaise with not only other elements of the medical and surgical teams, but also how you deal with patients. So these are all different features that I think have been touched upon, you know, how we communicate with patients, how we communicate with other members of teams, and also how we obtain our clinical skills. But really, if you look at each one has massive problems in terms of making sure that your trainee is able to do it, making sure that the trainee has a trainer that is able to deliver it, and also making sure that the feedback systems are set in place so that you know that the system as a whole is working well. Because you can set up a curriculum, but as was mentioned earlier on, if you don't do the measurement, there's no real way of knowing whether or not you're delivering what you claim to deliver. So I think a curriculum, which is broad and encompassing, and which is measurable so that you can get feedback on how it's working and it can evolve is really important. Now, that kind of system is generally what's in place in the United Kingdom at the moment, but these systems are always under evolution. So, for example, when Ehsan Khan and I were registrars together, we had a brand new curriculum that was set up in, I think, around about 2007. The curriculum had only been changed 3 or 4 years previously and has now gone through another revision. So these things are not going to be set in stone, even here in Pakistan. These will always change with time. And part of that is because medical and healthcare systems change, but it's also because that as we progress, we learn from the weaknesses of the past. So a lot of you've mentioned about how things were when you were training. Things have changed, you've become aware of that, and you understand that you need to implement change so that you can improve the system. So, I mean, beyond that, I can't really say very much more because it's really a massive area. But I think, you know, the most important thing is to start with a very robust framework that's measurable and that provides feedback and that can evolve.
Very
Thank
well
you very
said,
much,
well
sir.
said.
Feedback and monitoring was very important. Now we have Dr. Sadur Rahman from Shaukat Khanum, Lahore. Yes, Saad, please
So
give
we've
you
got a lot of junior doctors here, so I'm
Yeah.
very interested in hearing what
Yeah.
their thoughts are. But I think one thing that we haven't discussed so far is the role of technology and how technology adapt our new generation is as compared to us. So, you know, so short story, I'm not very good at telling them, but I've had many instances where I've tried to reprimand my trainee for using a cell phone
Yeah.
when they're in theaters. And actually what they're doing is reviewing the guidelines and the recent change in literature. And, you know, it doesn't look nice that someone is, you know, trying to enhance their information. And when we were trainees, the use of cell phone was more for extracurricular activities while you're in theater. So I think, you know, the new generation of trainees, they're more sort of in tune and with the new technology and using it better than their trainers are. And I think that's important for the trainers to realize as well. I think further I would
Ji. So, जी डॉक्टर एहसन आप कुछ डॉक्टर साहब के
मैं इस बात पे बड़ा सोचती थी कि maybe fault is in our trainees. We are very superb trainers and supervisors and educationists. But एक incident से I realized that the fault is not in our trainees. It's in us, in our system. थोड़ा सा एक छोटा सा वाकया शेयर करना चाहूंगी कि हमारे पास एक ट्रेनी था, बहुत ही नटखट सा, always used to come late, कभी थिएटर में टिकता नहीं था. We used to run around, see where he is. He's not in a theater or he's coming late, bunking the classes, everything. So he enrolled with us in a diploma in anesthesia. We thought he could never pass it. How can he go through it? But that fellow cleared his what you say IELTS and then PLAB, and was he then went to UK. उधर हमने सोचा कि ये इस सिस्टम में नहीं कर सकता, तो वहां पे तो इसको फौरन ही दूसरी फ्लाइट से ही वापस कर देंगे, the day he spent there. लेकिन believe me, he is doing very fine over there. He has done he is in a fellow of Royal College of Anesthesia program, and I think he has done part 1 and enrolled in part 2. So मैं इस conclusion पे आई कि fault is in us and in our system. Our students are brilliant whenever they are given proper forum and chance, they can prove their self.
जी डॉक्टर Rahman. Yeah.
Dr. Abid brought out this.
Dr. Asad, Dr. Asad.
Calling you Abid, I don't know. Anyways, I am that way.
Fault lies with him.
On a lighter note, your point was well taken, although I had to go for a toilet break, so I didn't mean to offend you, but I had to go urgently. जो एजुकेशन जो मेरिट है जो वो बड़ा जरूरी है कि एक स्टैंडर्ड होना चाहिए. I've been talking a lot, I've been quite vocal about it. MD, MS, MCPS, and okay, there are requirements कि minor लोग जो हैं मतलब पैसेज में जाएं वहाँ पे at least they should know the limitations जो patients को भेज सकते हैं. तो minor and major चूंकि हम लोग अंग्रेज से चले हुए हैं तो उससे पहले डिप्लोमा ही करता था वो जब उसे खत्म करने से 60-70s की बात कर रहा हूँ. So that is very important that there should be only one yardstick जिसके तहत आप करें. CPSP कर दें, MS क्यों करते हैं? MS is a non-clinical course all over the world, as you know. Everybody knows here, but people do get enrolled in MS. And when I talk to registrar of a university and saying, "Yaar, khuda ke waaste ye," in this very tone and this very words, "Yaar, isme MS nu to band karao." I didn't know that he himself was an MS, you know. So that didn't go down well. So, एक जिस तरह आप कहते हैं कि trainers are very important. और हमें जब तक responsibility नहीं लेंगे हम अपने लड़कों की लड़कियों की, और we have to introvert, we have to find out why do we want to train them? अब जैसे मुझे कहते थे कि यार मैं इसलिए ट्रेन कर रहा हूँ कि मैं भी कभी बीमार होके आ सकता हूँ. That should be the goal. These are your future generations. This is where your hope lies. You should make them better survivors, basically, not because के किसी और वजह से. And then, of course, the impetus lies. Life is being equated in dollars and rupees. What can you do? So, I think we are not at an impasse, but then we are somewhere near it.
So, yeah, moving forward. So, my next question is there any role of technology in the training program? Or?
Well, we have seen this use of technology when the COVID was here, and people were trying to develop some sort of programs on which they can teach online. Most of the courses were switched to online. And then we at AKU also developed some courses in which we actually do pre-testing courses and then post-testing online while the students were sitting at home. So technology is always helpful. Apart from that, there are other modalities, for example, Zoom meetings, where we can do interactive sessions. So technology is coming in and people are trying to use it to devise new ways of teaching in which it's just not the teacher who is continually sitting and talking about what what's in his mind, but he's also trying to learn what actually learner want to think and want to teach, what is thought about the topic. So basically, what I believe is the older traditional methods that we were doing in the past era, but now we have to devise these new courses with the help of technology in a way that there should be two-way interaction.
Thank you very much. Dr. Kamal, same question.
Yeah, I always have the last word, but please don't mind. देखो technology की डॉक्टर साहब मैं आपसे बात बताता हूँ. This came to me in 2003, 2004. That takes me 20 years back. I am a dinosaur, basically sitting amongst young guys,
Sir, Mike नजदीक.
मुझे लोग कहते थे कि हम ICU में काम कर रहे थे. Very basic चीजें थी, and I was infused with this thought कि यार लोग अपने हैं ये. So this guy came to me and he said कि sir ultrasound आ गया हुआ है. Sir वो फलां चीज आ गई है. मैं कहा सर आप लिखिए ना, आप इंडेंट कराएं ना, वो जो आ जाते थे. मैं कहा I won't do it. No sir, आप technology. I'm not turning away from technology. All I said to him was, the day you start writing notes 3 times a day about your patient, then we'll go for that also. You can't take out the human subject, human thing out of it. ये जो आप देखते हैं Renaissance और सारा सब, all they had was a board and a chalk. They started reading and writing. You guys have to understand that you have to. This is not your solution to your problem. These are not solution to your problem. Technology is not solution to your problem. The solution is your thought, that you start feeling things for you people. Ke ye patient hai, ye meri zimmewari hai. Then it all starts. I don't have anything against technology. I'm not a techno. savvy myself, but I would always like to say that a vigilant, a hardworking person can only utilize technology in the same way. The Angrez will tell you that enlightenment thi, but only then they started colonization also. 1555 and the Renaissance, and this was their enlightenment, enslavement and everything and whatever they did. So basically, I'm just trying to be a little off the tangent draw. Please, मैं आपको ये बताना चाहता हूँ कि जब तक आप बेड साइड मैनर्स, जब तक आप टेबल साइड मैनर्स, जब तक आप उसको नहीं करेंगे, even the machine is live, they will not respect you. They will give you wrong information.
Yeah, I fully agree
Thank
with
you.
Dr. Kamal. Basic
I
skills.
guess डॉक्टर फैसल ने talk दी थी difficult area management के ऊपर.
जी.
So there are scenarios which you cannot teach your trainees. They don't have the experience.
True.
So you can't give them the patient to by difficult area तुम इस पे practice करो and see कि difficult patient कैसे होती है.
Yeah, there are
with
some
the
areas
simulation
there.
based technique, the simulation based training, it is now possible to actually give them these scenarios.
Sure.
So technology will help train our new trainees.
Dr. Hassan, final words from your side on technology.
I think technology is important, and we can't really categorize that this technology is good, this is not good. Obviously, it has its it would always have its advantages and disadvantages, but this is technology is future. We will be employing more and more of it, but it will never be the sole. It will never become.
It cannot replace the human factor. So thank you very much, Dr. Khaled, Dr. Kamal, Dr. Hassan, and Dr. Salma for participating in this beautiful discussion. Both shukriya.
Thank you. Cheers.
So we'll close the session now, or next we'll take a 15-minute break and we'll start the next anesthesia session at 11:20. Thank you.
Thank you, sir. Mashallah, we disagree at many things, but then
So we'll start the next anesthesia session. So to chair the session, can I please invite Dr. Asma Khan? So Dr. Asma Khan is the head of Department of Anesthesia at Shaukat Khanum Cancer Hospital, Lahore. She's started she did her MBBS from Allama Iqbal Medical College, got her anesthesia training in Ireland. Her areas of interest include difficult airway management and quality assurance. So then thank you, Dr. Asma, for taking the podium. I think my other co-chair has just gone for a cup of tea. So we'll start here. So Dr. Asma, will you do the honors and introduce our speakers?
So our first speaker is Dr. Khalid Samad. He is consultant anesthetist and associate professor in Department of Anesthesiology in Aga Khan University Hospital, and his special interest in cardiothoracic anesthesia and trauma and disaster management and critical care.
Assalamu alaikum. So the topic of presentation is it's intraoperative cardiac monitoring. So before I start my presentation, I just want to take a vote. How many of here are using some kind of intraoperative cardiac monitoring devices intraoperatively? So basically, if we look at the definition, cardiac output is defined as the volume of blood ejected by each ventricle per minute. So it's basically a product of stroke volume and the heart rate. And it's a major determinant of oxygen delivery to the body, and it reflects the efficiency of the cardiovascular system. So to improve the oxygen delivery after optimizing hemoglobin and oxygen content, the next important and logical step is to improve the cardiac output. So as I said, people are basically, we rely on the blood pressure indirectly to measure the cardiac output and see if the blood pressure are normal, then obviously cardiac output will be normal. So in most cases, we don't measure the cardiac output, but it was first done by Stephen Stephen in 1733 by putting a manometer in the carotid artery of the horse, and was not until 1905 by a surgeon, Russian surgeon Nikolai Kotukov, who actually devised the mechanism to measure the systolic diastolic pressure. For cardiac output, basically Adolf Fick gave the principle. He was unable to measure the cardiac output, but he gives a principle of measuring the cardiac output. It is still considered as one of the standard technique for measuring the cardiac output, but it was not till 1970s that it was possible after the invention of the pulmonary artery catheter that the cardiac output actually can be measured on the bedside. So if we look at the classification, it is basically divided into invasive, minimally invasive, and the non-invasive. Multiple devices are available in the market based on the technique and the companies, from invasive to minimally invasive to non-invasive. And I'm going to discuss the technique of actually these devices available in the market and see how we can fit it in these devices into our medical practices. So if we look at the ideal technology for monitoring the cardiac output, is basic. It should be minimally invasive. It should be reliable, accurate, and reproducible. Give real time beat to beat cardiac output. Should have a clear data display available, so to make interpretation easy, and application at the bedside, and should be cost effective. So the first technique is thermal dilation technique, and this can be done by the pulmonary artery catheter. As I told earlier, that it's a gold standard for measuring the cardiac output. And in this, basically what we do is we inject the normal saline. We inject the normal saline, the cold saline in the right into the right atrium, and the sensor at the tip measures the difference in the temperature and gives this curve. And the area under the curve is basically the cardiac output. Same is for the transpulmonary dilation technique, in which again the injector is given through the right atrium, but it measures the difference in temperature at the tip of the arterial catheter, either in the femoral artery or in the brachial artery. So these are basically the invasive technique, and gives the give a reliable cardiac output. One of the modification is basically replacement with the copper filament in the pulmonary artery catheter, in which basically it gives a sequence of heating and recording, gives an average cardiac output after a short delay. It's also reliable for measuring the cardiac output. So one of the limitation for thermodilation technique is if there is a sensor malfunction, there is valve insufficiency, septal defects, and very low cardiac output. And again, there is a risk of several complication if you are going for an invasive device. So if you look at the literature support, there is a gray literature. Some articles supporting the use of pulmonary artery catheter, some are against the use of it. But in early 2000 articles, they basically are not in favor of using the pulmonary artery catheters. Support trial, Pacman trial, either they were against it or they were not in favor of using it. So again, a lot of literature, and the conclusion was basically that there was no benefit from the pulmonary artery catheter monitoring management. But the survey done in Swiss-based survey, web-based survey was done, and that has shown actually that 30% of the physicians are still using pulmonary artery catheter for monitoring the cardiac output, as the 56% are using transpulmonary dilation technique. So the question is whether the pulmonary artery catheter still is in use or not, it should be used or not, is basically the review article which was published in 2022, and what they said that it still remains a valuable tool in a wide variety of clinical settings. And what they suggested that the right selection of the patient population, that is high-risk patient with or without hemodynamic stability, undergoing high-risk procedure, as well as the right clinical setting, center with experience and expertise are essential in order for the patient to be benefit from pulmonary artery catheter. So before I move on to the less invasive devices, it is very important that how to validate new devices. So some kind of statistical analysis should be done to validate these devices. And this was basically reported by Kishley, which is called the mean percentage error. And what this said that 30% is acceptable to actually say that this monitor can be used reliably, intraoperatively, or in the post-operative setting. So one of the device is basically is esophageal Doppler device, and the catheter is placed through the esophagus and it face not the heart but the aorta, where it estimates the blood flow in the descending aorta and estimate the cardiac output by multiplying the cross-sectional area of the aorta by blood flow velocity. So advantage is basically it's minimally invasive, easier to insert, little training is required. But mainly the disadvantage that patient it's difficult to tolerate, and the readings can be there can be interference with the diathermy, and it's contraindicated if there is esophageal disease. If you look at the literature support, meta-analysis support that it can be used especially in patient in which we are using goal-directed field therapy, and actually decrease the post-operative complication in patient undergoing